morning, everyone. We're going to begin on time, and to make sure that we are respectful of everyone's time who's here, we do have a few members who will be arriving a little bit late, so we will do full member introductions later after they arrive. I am State Representative Ginny Cleavorn. I am the House-appointed chair of the Legislative Task Force on Aging. We have really great and exciting work to do together. This is going to be a collaborative committee. The focus of this committee will be the positive. What is the state of Minnesota doing well to create vibrant communities for individuals to age in community? In order to age in community, we need to have good, solid infrastructure. How do we provide housing? How do we do transit? How do we provide health care, et cetera? It is an extensive list of work that we have to do together. I want to make sure that we take the things that the state is doing well, amplify those things, make them broader, and make sure that they are serving all Minnesotans. Where we identify gaps, it is not blaming or shaming. It is, we have gaps that need to be filled, and how do we do that? And how do we do it in a positive way to serve Minnesotans no matter where they live in our state or their ability? If we are fortunate to live a long and ripe age, we will age into disability. So how do we serve our individuals with disabilities who are living in community? That's an important part of this conversation. So as we go forward, what I'm going to begin with today are not introductions of the committee as we wait for the other members to arrive, but we will begin with the enabling legislation itself. So I'm going to ask the committee researcher to please go to the testifying table and just walk us all through the legislation so that we know what is contained in the legislation that will guide our work. Mr. George, when you're ready, if you'll state your name and your title, and then begin your presentation. Thank you.
Chair Cleavorn and members, my name is Andrew George. I'm the LCC nonpartisan research analyst working with this task force. This presentation will just be a quick walkthrough of the bill that created the task force, as well as a brief overview of the open meeting law that applies to this task force. So this is Chapter 62, Article 2, Section 120 of Minnesota Laws 2023. So the goals of this task force are to review and develop state resources for an aging demographic, identify and prioritize necessary support for an aging population through state and local endeavors for people to remain in their communities, as well as to ensure that all aging-related state policies are inclusive of race, sexual orientation, gender, ethnicity, other abilities, and other characteristics that reflect Minnesota as a whole. There are 6 duties of this task force. The task force shall review the following: all current aging-related governmental functions, programs, and services across all state departments, the current plans to improve health and support services, and the review of current public and private strategies to support family caregivers for older adults, define and support quality of care and life improvements in long-term and home care, and sustaining neighborhoods and sustainable neighborhoods and communities for an aging population. As well, the task force will review the necessity and planning for the investment in aging in Minnesota to address the longevity economy and its impact on the workforce, advancing technology and innovations, housing options, land use, transportation, social services, and health systems, the availability of safe, affordable rental housing for aging tenants, and coordination between health services and housing supports. The final two duties are the task force shall review coordination across state agencies, tribal nations, cities, and counties to encourage resolution of aging-related concerns, And finally, from this review, the task force shall determine the governmental entity to plan, lead, and implement the recommended policies and funding for aging Minnesotans. Next, the membership of the task force. There are 8 members of the task force, 2 members of the House, 2 members of the Senate, the chair of the Minnesota Board on Aging, the chair of the Minnesota Council on Disability, the chair of the Minnesota Indian Affairs Council, or designee, director of the U of M Center for Healthy Aging and Innovation, or an employee as designee, and the Speaker of the House and Senate Majority Leader will appoint a chair and vice chair for the task force, and these chair and vice chair will rotate between each meeting. The meetings of the task force will meet at least once per month and take place in the Capitol. Per diem expenses, task force, the citizen members of the task force, that is the Board on Aging member and the Indian Affairs Council member, shall receive per diem, listed in Minnesota statutes. And the final report and expiration. This task force will submit a report of recommendations to the chairs and ranking minority members of the legislative committees with jurisdiction over health and human services, finance and policy by January 15th, 2025. And finally, the task force will expire on January 31st, 2025. Before I move on to the open meeting law, are there any questions on the enabling legislation for the task force? Seeing none, I'll move over. The open meeting law applies to this task force, Minnesota Statutes 13D. The open meeting law requires meetings of governmental bodies to generally be open to the public, and requires at least a quorum of the task force to be gathered in person, on telephone, or remote like we are right now, and discusses any topic related to the official business of that body, whether or not an action is taken. The law doesn't apply to subcommittees of the task force, which may happen with this group. The meeting is open if there's proper notice is given in advance of the meeting. The public can attend and observe the meeting, and relevant meeting documents are available. I'll just note that open meetings do not require public comment. I'll also note that this includes any email pertaining to the business of the task force, so just make sure not to reply all on certain things that don't need to be. Finally, the advice for open meeting law: if you like advice, individuals may contact their personal attorneys or the Commissioner Administration, and governmental bodies can contact the government entity's attorney, the Attorney General of the Government Administration. If there's any questions, I'm happy to take them now on the open meeting law or the enabling legislation. Seeing none. Thank you.
Thank you, Mr. George. I would like to remind the members who are around the inner circle, when you go to speak, please make sure you turn on your microphones. What we'll do now is, now that the members who have stated that they would be here are all present, we will do introductions, and then the question that I'm asking the members of the committee to respond to is, in thinking about Minnesotans, you and the entities, or the entities that you serve, is there an observation or need regarding aging in Minnesota that you want to make sure that we explore as this task force goes forward? It's just an icebreaker question. It's not intended to be a huge discussion, but to just give the general public some idea of the diversity of issues that we will need to discuss as we go forward. I'd like to begin the introductions with our members who are online. And if we can begin with Senator Kelly Morrison and then Senator Housley. So Senator Morrison, if you would begin the introductions, I would appreciate that.
Good morning, everyone. I hope that you're able to hear me. I'm sorry I can't be there in person today. I'm getting my son all situated to college, so I'm out of town. I'm really looking forward to this work together and was proud to chief author of the legislation in the Senate along with Chair Cleburne in the House. when I'm not a legislator, I'm a physician. So healthcare is often front of mind for me. So I'm very interested in all of the work that we're going to tackle, but particularly around the issues of healthcare and end of life care as part of the conversation as well. Thank you.
Thank you, Senator Morrison. Next, Senator Housley.
Thank you, Madam Chair. I am Karen Housley. I represent Senate District 39, which is Stillwater, Forest Lake, and the surrounding St. Croix Valley communities. This is, when I first got to the Senate, somebody asked me what areas of legislation and policy that I wanted to work on, and I said I didn't know, but quickly realized that taking care of our aging Minnesotans and being a voice for them at the Capitol has become a top priority for me. I think I said on the floor last year in the Senate, some people go fishing or golfing as their hobby. I like to visit nursing homes and assisted living across the state and check in and see how everybody's doing. So definitely want to address affordable housing. I've heard that's a big issue on our seniors' minds, and the healthcare and the staff in these nursing homes to make sure that we can keep them open for a place for our seniors to stay. So thank you, Madam Chair.
Thank you, Senator Housley, and thank you for being that advocate that we needed in the Senate for our older Minnesotans. Next, if we can move on to Maureen Schneider, if you would please identify yourself and talk about what's important to you.
Thank you, Madam Chair. Good morning, members of the task force and others who are here. I'm Maureen Schneider. I'm the interim chair of the Minnesota Board on Aging. I entered the aging field in 1990, having come from running my own company heavily in marketing. And it wasn't very long before I realized that we had a great deal of work to do. And over the last 30-some years, I have felt reasonably assured that that work had been done and that we were moving in a good direction. But over the past several years, as I've looked more and more deeply into some of the aging issues, I have realized that we need exactly what we have here with the task force, which is an opportunity to review and evaluate where we are, what is working well, and what do we need to still put our energy to make sure that Minnesota can be a place for all Minnesotans to age well and to live well. Thank you, Madam Chair.
Thank you very much. Next, if we could go to Member Foley, you'd please identify yourself and what's important to you.
Thank you. I'm Jennifer Foley from St. Cloud. I serve for the Minnesota Council on Disability. What's important, well, to me, affordable housing, being able to live in my own home, having affordable home care, staffing shortages that's come up. Those are the big things with me, and I hear that from a lot of my people in MCD.
Thank you very much. Dr. Gogler?
Hello, everyone. Thank you so much for having us on this very important task force. My name is Joe Gogler. I'm a professor at the University of Minnesota. It's also where I direct the Center for Healthy Aging and Innovation, who I'm representing here at this task force. And I think that's a great question to open up with. I feel like this, and perhaps this is more my opinion than anybody else's, is I would be disappointed if this task force ends up generating yet another report with recommendations and needs that basically doesn't go anywhere. I have sat on many statewide initiatives, for example, in dementia and other types of efforts that have created wonderful reports, excellent recommendations. There is never any follow-up in terms of metrics of success on those recommendations or whether they've been implemented successfully. And I think when I look at the landscape of aging in the state of Minnesota and where we need to go next to advance our work, it's, yes, we can identify needs. But can we then identify, okay, what are the strategies to implement and address these needs and then track to ensure that they're being successfully addressed and then sustained? If you don't do that, we'll just be here again in a few years. So I mean, that's, again, I'm admittedly speaking for myself, not necessarily for my center. I want to be clear on that. But I think many of us, certainly in the space of gerontology and geriatrics, there have been many solutions preferred. They do exist. We don't have to reinvent the wheel. It's more about how do we scale them up and disseminate them.
Thank you, Dr. Gogler, and I couldn't agree with you more. We need action. We are past the time of action, and we need action. So thank you very much for those heartfelt words. We have also members who could not be with us today. I believe that Representative Zalesnikar has been appointed a member from the Minnesota House as the minority lead for this committee, and also Councilwoman Agatha Armstrong with the Minnesota Indian Affairs Council has just recently been appointed the committee, and today was not a day where she was able to join us. So she will be with us at the next meeting. I am State Representative Ginny Cleavorn, and this work has been brought to us by community. You often will hear me say that our conversations drive my work at the Capitol. This task force came out of community conversation. It began and was led by citizens of the state of Minnesota, wanting to make sure that our aging population is seen, is heard, and is recognized. They are asking for a dignified way to live in Minnesota and how we can best help them be vibrant and remain in community. And that is the goal and objective of this committee work. And that's what brings me here today, and that would be my goal. Again, I want to make sure that we keep the conversation positive, that we look future-facing, and it is about creating the infrastructure we need to meet those goals that Dr. Gogler so brightly put, the action that needs to be done. And with that, I'd like to transition now to beginning with who are we as Minnesotans? How do we talk about aging, and what does that look like? We will have two presentations today. I would like to ask the state demographer to please come forward, Dr. Susan Brower. And if you would just kind of lead us into who are we as Minnesotans and what do we need? Thank you.
Okay. I'm ready. Good morning, Chair Cleavorn, members of the task force. I'm honored to be here with you today to talk about aging in Minnesota. I'm going to start with a general overview. Oh, thank you. Of how population aging is impacting our state, and then I will move into some more detailed data that shows the timing of the aging trend. And I'll also, with the data, paint a picture of the current experience of Minnesota's older adults, what their living arrangements are, their housing situations, very broadly, and a picture of their economic resources. My hope is that these data will help you anticipate needs and kind of the timing of the trends that we can expect, just given our population shifts ahead, especially to help you anticipate when these needs will become most acute. And I'll just let you know now that it's in about a minute. These needs will become most acute, so we'll look at that in a moment. Just very broadly in terms of the impact of aging on the state, aging will have permanent and far-reaching impacts on our policies, our institutions, our communities. We have already seen some of the impacts in terms of labor force growth. We've seen the labor force growth slow as older adults in the baby boom generation have moved into retirement. We haven't had the same level of growth in the labor force as we have in the past, and we've seen shortages open up. We've seen them open up in the area of care for our older adult population in many other occupations and industries. This workforce shortage, this slower labor force growth, was no surprise. We saw this coming for decades, and just as we saw the labor force slow because of population aging, we know that other needs will arise shortly because as the baby boomers move into these older years. Relatedly, population aging is associated with slower economic growth, or can be associated with slower economic growth. Across the globe, aging is associated with lower labor force participation rates, lower saving rates, and modest reductions in GDP. Research shows these reductions to be relatively small, but consistent and predictable, so a dampening effect on GDP. Public budgets will need to shift to meet the rising costs of healthcare and long-term services and supports, the needs of our aging population. Again, this is no surprise to anyone here, anyone in these rooms, but I state them now just to say this is still largely out ahead of us, very predictable in the way that labor force shortages were predictable 10 years ago, and we see them clearly today. These pressures are still coming and will still require public solutions. Tax revenues may be impacted by our aging population as well. Our federal and state tax collection systems are based on income and spending largely, which have a very clear pattern over the life course. Increases over the working years toward the end of the working years and then tends to decrease fairly quickly after retirement age or after retirement. The size of the impact of aging on tax revenues will depend on specific tax policies. But again, many of these changes are still largely or partially out ahead of us. Finally, from my perspective, most importantly, as a society, we still need to figure out how we will provide care for an aging population, and most specifically, not how in the program areas, but how we will choose to fund it and at what level we'll choose to fund it. Again, these needs are still largely out ahead of us. So let's look at the timing of the aging trend. Here we see the number of older adults age 65 plus between 1950 and projected to 2050. So it's 100 years of aging in Minnesota. We've just had the 2020 census. The number from the 2020 census is shown there in the gray bar. And we have from the 2020 census just under 950,000 older adults or those age 65 plus. A note about the measures in these presentations. I use 65 years and older in this presentation as a shorthand, but I recognize that aging begins before that and that many people in policy and program area use different age ranges to capture kind of the aging experience. For the purpose of this presentation, I've used 65 plus, but if there are data that you would like to see in other age ranges, I'm happy to provide those as well as you move on with your work. These are the same numbers. Oh, I'll just point out that our projections have us moving up very quickly to 2030 to just under 1.2 million older adults, and then staying at about that level into the foreseeable future. Move the wrong way here. These are the same numbers that we just looked at, but we're now looking at the change from decade to decade, and it really shows, this view makes it clear that the transition is happening now, and the movement to an older state is really concentrated between 2010 and 2030, these 2 decades, and that's as the baby boom generation reaches age 65. The growth of the older adult population will continue after that, but at a much slower rate. You can see there are very few older adults added after that time. That's because Generation X is very small. They'll be moving into those ages as well. If we were to continue that out, we'd see a larger increase after that as the millennial generation reaches age 65. My point is that we're concentrating this transition right now just because the baby boom generation is so large. If you remember nothing else from my words today, please remember this, that being a relatively older state is going to be a permanent transition for us. Our state was aging before the baby boomers reached retirement age and older. It was doing so because birth rates have been falling for decades. And when you have falling birth rates in a population, you slowly become older and older on average. And so we were moving toward becoming an older state. Even without the large baby boom generation, we will continue to move toward being an older state, to remain an older state into the future. It's the baby boom generation that sped this transition, and after this 20 years of transition, we will remain a relatively older state. And this is important because the policies that we put in place to address aging and the funding expectations, we're bringing policies into alignment with our future demographics. And so understanding this as a permanent kind of realignment into what we will be in the future is probably a important, helpful viewpoint of the work that's being done here. I've shown you when the aging of the state will occur or has occurred. I want to lay out for you a timeline of when some of the impacts will likely take shape. And we can do that just by looking at this range of years on this timeline. We're looking between 2010 and 2040. And you can see that the first half or so of the timeline, we're really feeling the impact in terms of workforce. And that's, again, as this large generation is moving out of working years into retirement, the brunt of that aging trend really is being felt by employers and also by people who are required to provide services for people who truly need them. So some of those workforce impacts are really being felt now. I'll point out that, as the baby boomers turn age 65, which is between 2011 and 2029, we're really not all the way through this transition yet. We still have a pretty big group of baby boomers in their late 50s who are poised to move into retirement. And so I would expect that some of the slower labor force growth that we have experienced will continue, and in some areas will the labor force even get smaller, particularly in some rural areas, as this generation moves out of its working years. So we're not kind of fully through that transition yet. I also want to point out that some of the impacts that we know are coming, and all of us know, and probably every Minnesota knows, that some of the impacts related to aging has to do with costs of healthcare and provision of healthcare and costs of long-term services and support, increased rates of disability. We all know these were coming, but they're still largely out ahead of us if we look at the age of the baby boomers as they are now. So the first baby boomer turned age 75 in 2021, and in those age groups, we start to see rates of disability really picking up much faster. We'll look at that in a moment, but the point is that we will start to feel some of the needs for these services related to healthcare, long-term services and supports needs, and disability in the coming years, just because that's when the baby boomers are getting to those age groups. Again, everyone knows it's coming. I fear that we will see people acting surprised in the next 10 years as it unfolds. So please don't do that. Minnesota isn't alone in the fact that its population aging. The whole of the U.S., much of Europe and Asia are experiencing aging as birth rates have fallen over the decades. And in fact, Minnesota is very close to the national average, at least by this measure of the percent 65 and older. 16.8% of Americans are over 65, compared to 16.6% of Minnesotans. So you can see there's a considerable variation across the U.S., with the darkest states on this map being the oldest, the lightest state there. I think Utah stands out as the youngest state, which has higher birth rates. But you can see there's considerable variation, but Minnesota is really experiencing this just as much of the U.S. is experiencing it as well. So even though it is the first time for us to align with this new demographic reality, we are not going it alone. There's considerable variation across counties as well. Rural counties tend to have a larger share of their population in the older age groups. As you can see, some of the counties that are darker tend to be in greater Minnesota, tend to be on the edges and northern part of the state where we have more rural counties. This is because of the outmigration of young people from rural areas over time and the lower birth rates that result from those outflows. Aiken County is the very darkest county, kind of in the center there, and I'll be showing you some more information about Aiken County in a moment. But generally, those metro counties tend to be younger, not only in the Twin Cities, but in greater Minnesota as well. So if you look, for example, at Olmsted County, where Rochester is, Clay County, where the Fargo-Moorhead metro is, you can see that there's those younger areas as well. Because rural populations have less density, it can be more costly to support healthcare facilities, including nursing homes, assisted living, to provide transportation to medical appointments, to provide meals and other important social opportunities. All of these things can be especially difficult in rural areas, and so I just wanted to point that out while we were looking at these numbers with this variation. Apologize that this is difficult to read, but I just wanted to generally give you the image that even though the rural parts of our state tend to have the largest population as a share of the total, do note that most Minnesota older adults do live in the densely populated areas. Each of the dots on this map represents 500 older adults. So the concentration is around the Twin Cities, where nearly half of all older adults in the state live. I want to point out an additional challenge for rural areas with respect to aging, and I'll do that by showing you what the population of Aiken County looks like compared to our oldest county compared to the population of Scott County, which is right here. So you can see in Aiken County, the vast number of older adults and the relatively small share of folks in their working ages. I know I've spoken with administrators of nursing homes in some areas with populations like these. And even before workforce shortages started to open up for Minnesota, across the state in the last 5 to 7 years, some of these administrators started to have trouble just because there were so few people of working age available to take some of these jobs. Of course, this has something to do with reimbursement rates as well, but generally I just wanted to share to show the reality of what some of these rural areas are working with when they're thinking about who do we need to find to care for older adults, who do we need to find who can personally be there to help assist with some of the care needs. And it's a very different situation than you see for a younger county as we see here, Scott County. So whether or not an ample supply of potential workers exists in a community, the workforce shortages make finding caregivers even more difficult because of increased competition by other employers. Right now, according to the most recent DEED data, there are job vacancies for 13,500 home health aides, PCAs, and nursing assistants, those three groups together, as you can see here. This is before the additional retirements further restrict workforce growth. As I said, we've got about 10 more years of retirements coming, so we'll see further restrictions. And this is before the aging population fully moves above that 75-year-old age mark. Wages that you see here, the median wage offering between $14 and $16 can make it really difficult to compete with anyone, even local retailers. And I know that's an issue that many folks have worked on here and have found some success. It's going to likely continue to be an issue. I'll say that I know many of you have worked on Medicare reimbursement rates and trying to create career pathways for some of these jobs. So I just wanted to note that I understand that work has been done. Those were important steps. But again, I expect, just given the numbers, the demographics that we have ahead, that those pressures will continue to be there into the future. The population of older adults in the state will continue to become more diverse, just as the state overall is racially and ethnically more diverse over time. What I want to share with you is that the proportion of older adults who are Black, Indigenous, people of color, who are BIPOC, is still relatively small. Just 9% of older adults, 76,000, self-identified as belonging to a BIPOC group in the last census. So this group will continue to become more diverse, but those changes are likely to be relatively slow. And if you look kind of at a population pyramid here, what we're looking at on the left-hand side are male, on the right-hand side are females. The lowest bar, 0 to 4, at the bottom of the graph, the blue portion represents white non-Hispanic residents of Minnesota, and the kind of grayish bars represent BIPOC residents. And so you can just see how a relatively small share of those older age groups are BIPOC, and that even if we think about the groups that are aging into those years, it's still a relatively small share. And I will say that you can see that over time, we would expect for that group to become more diverse just as that population ages into those years. But because of differences in life expectancy, really the reality is that growth is less than we would expect, just because many BIPOC older adults won't live into those older ages. So the Black-white life expectancy gap in Minnesota has found to be more than 6 years. It tends to be on the larger side of the gaps. And until these gaps narrow, growth in the BIPOC older adult population, it'll be slow anyway, but it will even be slower because of these gaps. Now I want to look at the way that older adults in Minnesota currently live. Most adults, 97%, live in households. They live in community. Just 3% live in group quarters or in nursing homes. And I know that many in this room, again, have done work for many years, for decades, to make this unfold in this way. I think it's important to know that the two most common kind of living arrangements for older adults is to either live alone, that's 28%, or to live with a spouse or partner, an additional 53%. So the vast majority are living in small households, either alone or with a partner. A small share also lives, about 1 in 10, 12%, live with at least one child of their own. If we look at the types of housing that older adults are in, most older adults are living in households that are owned. That's 78%, 22% are rented. A minority of owner households, 35%, have a mortgage. So most are living in a household that is owned mortgage-free at this point, owned outright. While some older adults live in large multi-unit buildings, we can see here the vast majority are living in single-family homes. A final note is that about 31% of all older adults are are housing cost burden, meaning they pay more than 30% of their income for housing costs, rent, mortgage, and other housing needs. So 30% is the average for older adults. Rates of disability rise very predictably. They climb in older ages as part of the normal aging process. Overall, the ACS attempts to capture the ACS is the survey that this is coming from. This survey attempts to capture 6 different dimensions of disability, and it's really one of the best sources that we have for the population of Minnesota and for smaller communities to understand disability in local areas. And so the areas that are captured here are independent living difficulties, whether someone has trouble doing errands alone, such as visiting a doctor's office or shopping, that's an independent living difficulty. A self-care difficulty is difficulty dressing or bathing, according to the survey. Ambulatory, serious difficulty walking or climbing stairs. A cognitive difficulty is serious difficulty concentrating, remembering, or making decisions. And then a vision difficulty is being blind or having serious difficulty seeing even while wearing glasses. And finally, a hearing difficulty is deaf or having serious difficulty hearing. And so I guess my point here is that we see these rates climb very steeply after the age of 75, and that's in part why I created the timeline that I created to show you that I believe some of these rates of disability really are going to climb steeply. We're going to start feeling the impact of those as that generation of the baby boomers reaches age 75 and older. 43% of all those age 75 and above have one of these disabilities listed here. We saw earlier that the majority of adults live in 1- and 2-person households, most commonly living alone with a spouse or a partner. Here we see the income distribution of older adult households, with 1-person households shown on the left, people living alone, and on the right, 2-person households, people mostly living in couples. This is showing income from all sources. It likely includes Social Security, pensions, property income, supplemental security income. When these sources are taken together, this is the total income of the household. While income, of course, isn't the same as wealth, wealth is a full accounting of all assets and debts, including the value of one's home, which we've already seen is an asset that many older adults in Minnesota have. And I have included some wealth data in your packets for the U.S. The Minnesota data aren't available just because of the surveys that they come from. They don't produce data at the state level. But I wouldn't expect that they would be too much different for Minnesota versus the U.S. overall, perhaps slightly higher. But generally, it's a good guidepost to give you a sense of the wealth of older adults to look at the U.S. The largest income group that we see on the left, people living alone, is less than 25,000, 110,000 people, followed by the next group up under 50,000 with about 86,000 people. And according to an elder index, which is produced by UMass Boston, it tries to give a sense of what the cost of living, covering basic expenses would be in different areas. So it's specific to Minnesota. You can drill down even specific to specific metro areas. This elder index that they put together suggests that for a Minnesota adult who's single, in good health, a homeowner without a mortgage, $24,000 is really kind of the basic level needed to cover basic expenses. So that just gives you a sense in looking at these numbers where distribution of income falls with respect to the expenses that people are likely to have. You can kind of play around with that index as well if you want to see different household compositions, different kind of health scenarios. But we can also look on the right-hand side where we see the income distribution for older adults who live as part of a couple. Their incomes frequently fall closer between $50,000 to $74,000, a little bit higher income because there's two of them. And according to this elder index for Minnesota, $37,000 is needed to cover basic living expenses if the couple doesn't have a mortgage, $49,000 if there is a mortgage. So again, even though there are some healthy incomes up here on this chart, there's a fair number of people who are likely just getting by as well. Another measure of economic well-being, the poverty rate, shows that poverty has been dropping among older adults, especially if we look back to 1960, where the poverty rate was 42%. Since that time, federal programs like Medicare have been enacted, and the poverty rate has steadily dropped. You can see the U.S. line kind of behind, so we closely follow the U.S. line. I will note that Minnesota and the U.S. both saw a small but significant uptick in poverty according to the last census data. The 2022 numbers will be released in mid-September, and so we will continue to watch this, but it's just something to note. It's not clear whether this was kind of related to employment around COVID or if there were some longer lasting or more serious underlying issues related to retirement income that we're seeing here. Finally, I want to share a piece of research that was conducted by researchers at the Urban Institute looking at the Health and Retirement Survey, again, a national survey, so we don't have Minnesota data. But what these researchers did was to estimate how many older adults had the ability to pay for their own long-term services and supports, whether that would be care in their home, in assisted living, or care in the nursing facilities. The results are really sobering, that a minority of older adults lack the ability to pay for their own long-term care, and the vast majority of those with severe needs lack the ability to pay for their own care. So for a sizable share of the population, these services will be needed, some for a significant amount of time, and the majority do not have their own resources to pay for these, which underscores the importance that many of you have been doing for decades and that this task force will continue to do. And so, kind of in sum, we have serious and significant work ahead of us. We have a lot to build on. Population aging is happening now. We're right in the middle of this massive transition, but the costs of aging, the costs of paying for the care are really largely out ahead of us, and I think they're about one blink ahead of us. I think it's not far. Policies, programs, and solutions that are put in place today will serve to align us with what future populations will likely also need. And to my mind, one of the most pressing issues is how we will care for older adults. Will programs be funded to the levels that we need to truly provide dignity that we hope we will have when we are old? Will we as a society be able to ensure that important caregiving jobs are filled? These are still open questions. As one of the task force members already pointed out, we have solutions to many of these things. Will we be able to ramp them up to the scale that is needed in the coming years is an open question in my mind, and I am pleased that this task force is here and working on it. Thank you.
Thank you, Dr. Brower. Before I ask my questions of you, I'll just ask if there are any members of the task force that have questions they would like to ask Dr. Brower. Dr. Gogler, did you have a question?
Yeah, I always appreciate these reports. I mean, we're familiar with them. We look at them quite often, Dr. Brower. And I mean, I think this is less a question than maybe more of a reflection on this, and I think many other demographic estimates when we think of aging, not just in Minnesota, but across the U.S. and beyond, is, I mean, when one looks at the report, and I'm very glad you didn't use this term, Dr. Brower, you hear the term in the media, aging tsunami. It's coming. What are we going to do? You know, that kind of thing. And I don't dispute any of the data here, any of some of the challenges and concerns. But I think philosophically for this task force, really for all of us as a society, is thinking also about this, just because we're older doesn't mean there aren't many strengths, opportunities that we, as of yet, aren't taking advantage of. Dr. Linda Fried, who's a world-renowned geriatrician from Columbia, she came and gave a talk at the university 4 or 5 years ago, and I'll always remember her saying this, which is the fact that we look like this as a society is actually a major public health achievement when you look at past history.
Yeah, really.
How we've been able to age. And again, the traditional age demarcation point is always 65 years of age, and that's always what it's been. But you can make a real strong argument. Is that really even relevant anymore? When you look at the health of 65, older people who are 65 and such. So we can't lose sight of the fact that, yes, this poses challenges and such, but I think there are also some amazing opportunities to take advantage of as well. And framing this as this is a crisis, a tsunami, et cetera, I don't think will lead us to good solutions. And I'm not saying you did that, Dr. Bauer, but I think it's just framing this in the overall conversation of our work as a task force, so.
I couldn't agree with you more. It's really important. And that's why at the very beginning, when I said we want to make sure that we are creating opportunities for people to remain vibrant, there are many opportunities here for us to explore and discover. So I really appreciate those comments. Does any other member have a question? Ms. Snyder?
Thank you, Madam Chair, and thank you, Dr. Brower. I took a quote down when you were speaking that really resonated with me. You said the fear would be that people will act surprised as the projected aging demographics come to fruition or manifestation. And that, to me, is one of the things that we need to be the most careful about, is we do have many, many assets. We have done a good job. We've worked hard. However, one of the things we lack and probably will continue to lack because of human nature is the lack of awareness, general awareness of the availability of some of the great services that Minnesota has in place. I don't know how to change that. We generally do not start looking at aging issues until there is a crisis in a family or a loved one. But I do know that we need to do a better job on explaining to the general population that we've already worked hard and we have assets available, but they need to be aware of them. Thank you.
Thank you very much. Any further questions? Welcome, Representative Selesnikar. Would you like to introduce yourself for the committee? And then if you have any, the general question I ask people was what brings you to the table today? And so if you would like to just take a minute or two to talk about why you're at this table, that would be awesome.
Thank you, Madam Chair, and I'm sorry I'm late, but I was with Chair Knorr and Senator Hoffman touring nursing homes this morning. So why am I here? The why is I've spent the last 40 years caring for an aging population. I started as a nursing assistant in high school and became a licensed nursing home administrator in 1991. And then I co-founded a small assisted living for higher care needs in northern Minnesota. And I retired my license and decided to run for House of Representatives. And I'm here, I think, because this has been my life, caring for people with disabilities and seniors and hopefully finding solutions, which I believe there are great opportunities. It's great that we're living longer. I think we just have to find some different opportunities to think differently and prepare differently. So thank you for letting me be on the committee, and sorry I'm late, but I was at a nursing home.
It's great to have you with us, and I'm glad you could join us for this portion of the meeting today. Dr. Brower, are there any other questions from the committee members? Okay, so my question is around averages, right? Averages can sometimes be a little misleading. And as you talked about greater Minnesota and the younger outward migration of individuals. My question to you is, do we have any data around how many Minnesotans are living? I mean, I saw the general number of who lives in a household by themselves, but I'm thinking about just the general family dynamics. Do we have any information on family dynamics?
We have information at the national level that gives us a sense of how many potential caregivers, how many children, so there are surveys that collect that information. And so I'm happy to share that with you. They don't collect it in a way that's possible to publish it for smaller geographies like the states, counties, and so forth. But it's going to generally give you a sense of who potentially is available. And generally, what we see over time because of demographic changes, smaller family sizes, is that there is a restriction in the number of potential caregivers because there's fewer kids, fewer siblings. But I'm happy to share that national data with you.
One moment, please. The other question I had for you, and this is just a broader question, and I don't know if you're prepared to answer it today. I should have asked you before you came. When we think about Minnesota's workforce, because you mentioned workforce quite a bit, I don't know where I have this number in my head, but I recall seeing a chart somewhere that the working population really falls dramatically after the age of 58. So the question I have is, do we have any data on how families are or individuals are bridging that space between 58, where they leave the workforce either voluntarily or involuntarily, to the age of 65, where they make, or now it's moving to 67, where they would qualify for their Social Security benefits. Do we have any data about those numbers?
There are detailed data on the income of older adults, again, at the national level.
Okay.
And it shows kind of sources of income. It tends to drop with age as employment drops off, but I'm not sure that's getting exactly at what you're asking, so.
Well, I'm just concerned, there are, as we are thinking about going forward, if we have individuals who are being removed from the workforce at 58,
Yeah.
right? How do they bridge that space where they're not really classified as older Minnesotans, right? But they're also burning down whatever savings they might have that would help them prepare for moving into that full retirement age category. So I'm just thinking
Okay.
about what the demographics around that might
Okay.
be as well.
Yeah, I'm happy to look into that some more and see if there's anything useful I can come up with to speak to that.
Thank you. And Representative Selesnikar.
Thank you, Madam Chair. I'm just going to ask a couple questions following up on something you mentioned. And my question is, do we have any data on how many seniors are working that are on Social Security? That's my first question. And my second question is, if we have any data in the state of how many public school, high schools in Minnesota have health occupation classes in the classroom, in the school, similar to what existed in the 80s, which was my pathway to become a CNA to enter the field. So those are my two questions. Thank you.
We can run a tabulation to see how many older adults are working who are also on Social Security. I don't have that in front of me, or I haven't run that, but that's certainly something that can be tabulated. In terms of public health occupations in high schools, I'd have to track that down. I'm not sure.
Dr. Gogler.
Yeah, to follow up on that, I don't think this is a question for demographics, but I would like to know, in addition to health occupation class, is there any education at all about aging and gerontology in any health class in high school in Minnesota? And if so, what does that look like? My sense is, from what I can tell, I mean, and I don't know this systematically, I think it's very, very limited. Which, again, based on what we just heard from the state demographer, that's a big disconnect, I think. So that's something perhaps this task force can look into.
Maybe the next question that I would have for the committee members, and Dr. Brower, thank you for that, for your presentation. Are there any more questions for Dr. Brower? All right. Thank you so much. If you'll just kind of hang around for a while, if you have time to do that, I'd appreciate it. Members, as we're going to hear one more presentation, and then if you'll kind of think about the topics that you would like for us to explore going forward, or people or entities that you would like to have come in and present that we can plan for future meetings, we can discuss that towards the end. So our next presentation is the Area Agencies on Aging. Carrie Benson and Lori Frolson, if you would like to both attend the table, that would be great. Okay.
Thank you, Madam Chair.
Thank you. If you'll state your name for the record and then begin your presentation. Thank you.
Thank you, Madam Chair. My name is Carrie Benson. I'm the Executive Director of the Minnesota Board on Aging, and I get the pleasure here of just teeing up the real presentation for you all today, which is from one of the area agencies on aging. And so I just wanted to provide a little bit of context for you all before turning it over to Lori for her presentation. Sorry, just experiencing a technical difficulty here, Madam Chair.
All right, Mr. George will help.
Thank you. So I just wanted to provide an overview of the Minnesota Board on Aging for you all, and just as I said, it would be a brief overview. The Minnesota Board on Aging is the state-designated state unit on aging for purposes of administering the Older Americans Act. Okay, thank you. And it has a long history in the aging field. It began as the Governor's Citizens Council on Aging, Citizens Council appointed by the governor to represent all areas of the state and represent the voices and be the voice for older adults in the state. In 1965, with the establishment of the Older Americans Act, the MBA became the designated state unit on aging for purposes of administering the Older Americans Act, and then the actual name change to the Minnesota Board on Aging took place in the 1970s. I wanted to show this visual for you all on the National Aging Network, just so that you are able to place kind of in the larger context, the Minnesota Board on Aging, and more importantly, our area agency on aging and service provider partners. So you'll see at the top of the screen, the U.S. Department of Health and Human Services and the Administration for Community Living. ACL, as we have that as with many acronyms, ACL oversees the Minnesota Board on Aging and our use of the Federal Older Americans Act dollars, designates us to do so as it does the other state agencies on aging, and also awards funding to Indian, tribal, and Native Hawaiian organizations. The Minnesota Board on Aging then in turn designates the area agencies on aging, and you'll see that's similar to all the other states in the country as a part of our National Aging Network. In turn, the area agencies on aging play critical roles in the regions that they deliver services in and plan and coordinate services in their regions with many service providers at the very local community level. The Minnesota Board on Aging's mission is to ensure that older Minnesotans and their families are effectively served by state and local policies and programs in order to age well and live well at home. We serve under the leadership of Interim Chair Schneider, who is a member of this task force, as well as 24 other members appointed by the governor to serve 4-year terms. They represent, as with the earliest version of the Minnesota Board on Aging, they represent all areas of the state and all the voices of Minnesotans. So with the administrator role, as you'll see 3 roles for the Minnesota Board on Aging, with the administrator role, that's really where we partner most directly with the area agencies on aging. And together, we touch over 200,000 older Minnesotans today with the range of services that we provide. We show this visual to show that we are reaching individuals early on in their need for services, when they might just need a home-delivered meal, might need assistance through the senior linkage line, which the Minnesota Board on Aging administers in partnership with the area agencies on aging, or they might need assistance while living in a nursing home, advocating for their rights with the support of the Ombudsman for Long-Term Care Program. So I'm very excited that you will be hearing from one of the 7 area agencies on aging that the Minnesota Board on Aging designates and has the pleasure of partnering with in serving older Minnesotans, as they really do have the feel and the perspective and the awareness of the needs and preferences of older adults in terms of the services that they receive, the gaps that they might be experiencing, the challenges that they're experiencing. And so we're very excited to have Lori Vrolson join us to provide that presentation.
Thank you very much. And with that, we will go online and hear from Ms. Vrolson.
Welcome, everyone. Thank you for having me here today. And can you see my screen?
We only see you. If you can share your screen, that would be wonderful. We can now see your screen. Thank you.
If you can. Okay, great. All right. Well, thank you, Madam Chair and the task force members for the opportunity to be with you this morning to talk with you about the roles and perspectives of the Minnesota area agencies on aging and about the trends and gaps that we're seeing in the state. I'm Lori Vrolson. I'm the Executive Director of the Central Minnesota Council on Aging. So as Carrie said, in Minnesota, there are 6 regional area agencies on aging and then 1 Minnesota Indian area agency on aging that covers the state of Minnesota. So the Central Minnesota Council on Aging, we are designated as the area agency on aging for the 14 counties in the purple color, which is home to about 183,000 older adults. As area agencies on aging in Minnesota, we have 4 core functions. First, we connect older people with services and resources in partnership with the Minnesota Board on Aging through the provision of the senior linkage line, which last year reached more than 125,000 individuals, either over the phone, through online chat, or in-person assistance. We also fund community partners to provide critical in-home support services, caregiver supports, meals, as well as health promotion through Older Americans Act grant dollars, which impact 1 in 6 older adults in Minnesota. And then we spur collaboration to innovate and develop services, and we advocate for resources and systems change. So the Minnesota Board on Aging, they receive approximately $22 million annually of federal Older Americans Act and state nutrition funds that they distribute to the 7 area agencies on aging using an interstate funding formula. So with 1.3 million older adults in Minnesota over the age of 60, that equates to about $17.31 available per 60-plus older adult in our state. So with that, area agencies on aging really look at the local level on what is needed to support older adults to remain living in their homes effectively. And we really target that Older Americans Act funding to individuals that are frail, socially and economically underserved, including diverse elders and older adults in rural areas. Older adults, the Older Americans Act services are often the only services available in rural Minnesota. Additionally, rural Minnesota does not have the robust philanthropic funding or booming network of nonprofits that are always available to fill the needed gaps. As area agencies on aging, we are also very intently working with the growing diverse population of older adults of color with higher poverty rates, especially for Black and Hispanic older women, lower life expectancies for Black and Indigenous older adults, and greater housing instability for our BIPOC seniors. So the area agencies on aging play both the key roles are planning, developing, coordinating, and delivering a wide range of long-term services and supports to communities throughout our state. And we tailor this to the local needs. We know that 90% of older adults say that they want to remain in their own homes for as long as possible. We have about 4% of older adults that live in assisted livings in Minnesota at an average out-of-pocket cost of $45,000 a year, and 2.4% live in nursing homes. So the vast majority of older adults do live in the community, but often will need to connect with needed formal services in addition to the informal supports that are being provided. So today I'm really going to focus on three key emerging gaps for caregivers, meals, and transportation. We're very fortunate in Minnesota that we have 640,000 family caregivers. And when I say family caregivers, I'm referring to spouses, aunts, uncles, grandchildren, as well as neighbors and friends that are helping older adults remain living in their own homes. And this care that they're providing is estimated at $8.6 billion a year of care to older adults in Minnesota. And this far exceeds our Medicaid expenditure for nursing home and long-term services and supports in Minnesota. So it's very important that we look at how we can continue to support these family caregivers and equip them with the right mix of training, tools, and resources so they can continue to do that as long as they're able. In terms of the family caregivers, most are women with the average age of 49. And this was alluded to a little bit in their first presentation in terms of individuals that are in the workforce and as they're aging, how they may be exiting. And some of that is attributed to caregiving responsibilities. We have about an estimate 61% of family caregivers that are in the workforce, but many of those are decreasing their amount of hours that they're working to be able to accommodate their caregiving situations as well. On average, a family caregiver will care for somebody for 4.5 years, but we are also seeing that length increase. So this is not a stage in life that goes by quickly. We're also seeing that over 170,000 family caregivers are caring for somebody with Alzheimer's. So it's increasingly important that we have a variety of services available to support family caregivers. And one that is in particular critical is respite care. And thinking about respite not only in traditional sense of very valuable services like adult day, but also thinking about how can we support family caregivers with their roles that they're doing and giving them a break in some of those roles, whether it's having a volunteer that can take that care recipient to the grocery store to do their grocery shopping or to medical appointments, or a PCA that can come into the home and do personal cares and maybe some like housekeeping, laundry services. Those are all all very important forms of respite that can further support our family caregivers. We have also seen that as individuals are receiving dementia diagnosis, often families and patients receive limited direction on what to do next, with very limited suggestions on the array of non-medical supports that are available in communities for those families to tap into. So we must continue to develop models that integrate services across community-based services and supports with our primary care network that is out there. In terms of food, Minnesota must have a reliable source of food for frail and food insecure seniors. We must invest in relatively simple, low-cost services that support older adults to live at home by ensuring that they have healthy food options. And this is key. Food insecurity disproportionately affects older Minnesotans from lower income and rural communities who often live in food deserts, have limited English proficiency, or lack access to transportation. Inadequate nutrition impacts their health, quality of life, and increases healthcare costs. We can help to prevent these consequences by ensuring that low-income and health-compromised seniors have the food that they need. The Meals on Wheels and congregate dining programs reach older adults that are food insecure or individuals who may not be able to prepare their own meals. In addition to the nutritious value of these programs, it also provides both socialization and daily safety checks for individuals, for example, if they're receiving home-delivered meals. We are seeing, though, that traditionally our home-delivered meal programs were providing daily hot meals to older adults, and as the volunteer shortages are impacting their program, as well as workforce shortages and not having enough, for example, cooking site staff, we are seeing these programs that are having to move to, instead of doing daily hot meals to individuals, having to supplement that with maybe a hot meal once or twice a week and frozen meals the remainder of the time. In central Minnesota, during COVID, we began to hear from our food shelves that they were seeing 30+% increase in older adults using the food shelves. And many of them were first-time users of food shelves. And so we began to pilot with our Older Americans Act meal program, frozen meal bundles, where they partnered with 19 food shelves in our region, and once a month they bring to those food shelves frozen bundles of up to 20 frozen meals that these low-income seniors can take home with them in addition to their food commodities. And with this program last year, for example, we reached 2,600 low-income seniors in partnerships with the food shelves and provided them with just under 200,000 meals. So it's been one avenue to try to reach really those individuals that are most food insecure. We have also seen a dramatic increase in the meals that is driven by the increased costs for groceries, reduction in SNAP benefits, increased housing costs, and it's just getting harder for these individuals to stretch their limited income. So our capacity to serve will continue to be challenged as food costs continue to rise and older adult population continues to grow without the funding that is really keeping pace. I would note, though, that the Area Agencies on Aging and the Minnesota Senior Meal Coalition is very appreciative of the increase that was provided through the state nutrition funds this past legislative session. Finally, I would like to touch on transportation. As we see the high demand and growing challenges of transportation services, especially for assisted transportation. AAA has reported that older adults outlive their ability to drive by 7 to 10 years, and 1 in 5 older adults do not drive. And this is not new information to us. We have seen since the onset of doing the Department of Health and Human Services gaps analysis that started in 2001, that transportation ranks as a top gap on every gaps analysis, and that's across the entire state. So whether it's in urban areas or in rural communities, transportation continues to be a key gap. But older adults in rural Minnesota face the most serious obstacles in getting their transportation needs met. We are very fortunate, however, that in Minnesota, we have over 77,000 volunteer drivers that provide annually about 168,000 rides to individuals to grocery stores, medical visits, social service appointments. And transportation is one of the key areas that the area agencies on aging fund Older Americans Act dollars for. So we really know firsthand what are some of the challenges and specific issues that are facing volunteer drivers programs. And this includes shortages of affordable transportation that accepts clients with wheelchairs and other assisted devices. We do have a shrinking volunteer pool. We're also seeing that oftentimes our volunteer driver programs are having to actually have two volunteers go to escort individuals, especially if the rider has cognitive decline, that in addition to the driver, they actually need an escort volunteer along with them. We also see an increase need for drivers from diverse cultures, especially for individuals that have limited English proficiency. One of the key advocacy avenues that the Minnesota Volunteer Drivers Coalition right now is working on is federal tax reform that would allow a volunteer driver to not be taxed on mileage reimbursement. Currently, any mileage reimbursement that they receive over 14 cents, they are taxed on this. And so we're trying to have that be set at the federal business rate. We also have a need to increase the awareness about the available transportation options that are available in communities so individuals can develop their own mobility plan, as well as increase awareness in the communities for the need for more volunteers as a whole. So these are just a sampling of some of the transportation challenges that we're seeing. On behalf of Minnesota Area Agencies on Aging, I thank you, members of the task force, for your commitment to older adults and for the opportunity that the task force has in front of them to reframe how we consider solutions that will make Minnesota a great state to grow old. We know that data such as that has been presented to you today is critical, but we also need to be realistic about the needs and lack of financial resources and the declining nonprofit sector that's serving older adults. But on the positive note, you know, we have the positive changes that are in front of us today. The task force itself, the age-friendly console, new funding from the state legislature for senior meals, and the effective coalitions that area agencies on aging are co-leading with other advocates and policy changers in the state. And so there's a tremendous amount of best practices that are out there that we hope in the future, at future task force meetings, we would have the opportunity to be able to share with you on how, just to highlight some of those unique programs that are out there that could be replicated across the state. So with that, I thank you.
Thank you very much for your testimony. We appreciate it. I'd like to open up the conversation to questions from the members for either Ms. Benson or Ms. Burleson. Members, do you have any questions? Senator House, do you have any questions? No questions? Okay. Thank you very much for your testimony. We appreciate hearing from you today. Dr. Brower, a question was handed to me from a member of the audience here today. And the question is, could you please talk for a moment, if you have information with you, about single women 65 plus who are falling into poverty? Is there any specific data that demonstrates that this is a trend?
I don't have that data in front of me or in my head, but I know that this is something that has been tracked recently, and so I guess I'd like to go back to my notes to see how the uptick in poverty in the last year, between 2020 and 2021, is reflected when you look specifically at women. So that's something I'd be happy to do. I know generally, I showed you the trend long-term for men and women is declining. It's that most recent year, that uptick that we've got questions about, and I can certainly look and see what the impact was for women versus men. Yeah.
The other question I might have for you that I didn't ask earlier is, when we talk about Social Security income, do we have data on how that's broken out, right? People tend to think of the definition of Social Security income as what they personally receive, right? But I don't know what the state average is for individuals receiving Social Security income. Do you have any of that data?
That data, the data are out there. They're not in my head, but I'm happy again to provide them after this.
That would be wonderful, because as I said, averages are important. And I always say, there are very rich people, if they came into this room and I was sitting with them, our average income would be high, but that doesn't mean Jenny Cleaborn has money in her pocket, right?
I'm happy to show kind of the full distribution of Social Security income that Minnesota seniors receive or report receiving.
Oh, that would be wonderful. I would appreciate that. Any further questions from the committee? Representative Selesnikar.
Madam Chair, thank you. My question is just, the data shows that Greater Minnesota has a larger portion of aging seniors that are older, if I read it right. And from my experience, that older generation in Greater Minnesota has then a higher number that may end up needing long-term care services for a nursing home. And so I serve on workforce committee too, and my concern is just what we're doing on the childcare side, because if we don't have childcare for workers, Greater Minnesota has lost, I think we need to look at the data on family childcare, because there's over 1,000 childcare providers we've lost in the family model of childcare in the last year. We have not lost any in the centers. The metro suburban area tends to have more center-based childcare. In Greater Minnesota, it is family-based, and nursing homes are shift work. And so we need to have the family model of childcare strong so that we have people to work on the holidays, on the second shift, the third shift. So I would like to see some correlation to that piece too, because Greater Minnesota has to have daycare so that we have workers in those settings. Thank you.
Thank you very much. Dr. Brower, do you have any comments for that, or is?
I just know that the Center for Rural Policy has done some great work, specifically looking at the need for childcare in rural areas, and I'd be happy to pass that along if you haven't seen it.
Thank you very much. Dr. Gogler.
Yeah, it's more of a thought and reflection. I think on the last two presentations, I'll admit up front, I'm very biased. I'm a big fan of the AAAs. They've been a great partner of ours. Lori Vrolson, of course. I know Dawn Simonson's here, Kari Benson too. One thing I think we should think about broadly when we consider all the different aging programs and services out there, and you heard the presentations touch on this a little bit, is, in my experience, one of the centers I direct at the university is called the BOLD, Building Our Largest Dementia Infrastructure, Public Health Center of Excellence on Dementia Caregiving. It's funded by the CDC, and the goal is to engage public health agencies across the country to elevate dementia as a public health concern. And a big emphasis that we have is trying to get state departments of health fully engaged with everything that's going on in terms of dementia services and supports in their given localities. And one of the things we found is how much funding creates artificial silos across these different entities. So traditionally in many states, something like dementia or aging more broadly isn't considered a public health issue. It's the aging service network. It's the AAA issue. And part of this is due to, I would argue, funding silos that are created, not necessarily at the state level, but the federal levels. How AAAs are funded versus how departments of health are funded, quite frankly, to how disability services are funded. They all come from different channels, and that has created these artificial silos that have created barriers to true coordination. The more, I think it's very important for us to realize and recognize that when we're looking at Minnesota, when thinking of creative ways to break down those silos. Because traditionally, these funding arrangements, I think, have created artificial barriers, if not in Minnesota, certainly more broadly. One last thing about the AAA, I'm sorry if I'm monopolizing, Chair, I'm sorry. I just think, because these are great presentations, it sparks a lot of ideas in my mind too, is why I'm a fan of the AAAs is if one looks at their funding and say compare it, for example, you heard Ms. Rolson talk about the Family Caregiver Support Program. If you look nationally at AAAs, they basically serve, I want to say, the last stats I've seen, between 700,000 and 1 million caregivers across the U.S., which is a sizable number. Their funding federally is roughly $190 million. Contrast that to the VA, which has really the gold standard family caregiving support program in place. It's a spectacular program, what they offer family caregivers of older veterans. The VA gets, I believe, $1 billion and serves around 32,000 caregivers. I mean, and I'm not saying that the VA should be cut and that money, not at all. I mean, but what I'm saying is that understanding how these services are funded and right-sizing them is very important when we think of policy solutions. Maybe it's limited in terms of what we can do at the state level, but still understanding that context is really important. So.
Thank you, Dr. Gugler. And I think one of the important things for our listeners to understand and for our committee is we are doing a deep dive into what's there and how we can better streamline those services that are there and how we can possibly create infrastructure that would allow us to provide better services. And I think those barriers to coordination are an important thing for us to look at. So we'll plan that for a future meeting. Are there any other questions for Dr. Brower? Does Senator Housley have any questions? All right, thank you, Dr. Brower. So that'll move us into any other topic areas that the task force would like for us to just kind of, top level things that we need to plan for future meetings. I would anticipate that our next meeting would be the Minnesota Department of Health, Health and Human Services, to come in and speak with us about what we are doing. And again, I want to make sure that we are very focused on how do we build forward. It's not blame and shame. It's not screaming, yelling. It's how do we build forward and what's working well and how can we improve that system. Do members have any topics that they would like for us to discuss in future meetings that we can help plan for? Ms. Schneider.
Yeah, thank you, Madam Chair. A few things that have jumped out at me as we've been listening to both Carrie Benson's and Lori Vrolson's presentations. I would like us to have some time to talk about the informal caregiving role. Lori brought that out in her presentation. $8.6 billion a year in care for older adults. So when you think about the task before us in the demographic projections, I don't see a way right now where we would ever be able to fold that a dollar amount into the care that needs to be provided by caregivers. So I think we need to have a high respect for the value of the work that informal caregiving brings to the aging network. The second thing Lori talked about was the demand for home-delivered meals, and some of that, of course, is pandemic-related. We know that people could not get to dining sites. But I think another byproduct of that has been the concept of isolation among older adults in Minnesota, which comes with another set of challenges. So we need to be thinking about that. And then finally, on transportation, we know that transportation services always rise to the top whenever we are doing an assessment or an evaluation of gaps in older adult services. Now, I come from a greater Minnesota area, and one of the things that I'm working on right now is rural transportation with the Regional Transportation Coordinating Councils and the MnDOT grants. And one of the things that we're grappling with that I think we're going to need to get a handle on is it has been very difficult to get an actual cost of transportation for seniors. And in talking to providers, I find that they are really always not sure of their actual costs, because there's a difference between a senior who hops on a bus or a van for a paid-for ride and needs relatively or no assistance. Contrast that to a senior who has a disability or multiple disabilities, who needs assisted transportation, who needs door-to-door service. And I think we need to, when we're talking about transportation services, because they are so critical, we need to have a very serious eye towards what are we actually paying for and what is this likely to cost us in the future. Thank you, Madam Chair.
Thank you. And Senator Housley, online.
Thank you, Madam Chair, and I want to thank Dr. Brower and Kari Benson and Lori Volson for those presentations. They were very, very informative, so thank you. There are a couple of things that I would like us to work on in this task force and it was touched on in the three gaps, but the workforce, those that care for our seniors, we really have to do a deep dive on the workforce issues and how we can help solve that. Also, how can we give seniors a purpose? They age much better if somehow they can connect with others in the area when it comes to church or discussion groups or fitness or hobbies. That's one area I would like to have us focus on. And also, and I know this happened in our Aging and Long-Term Care Committee, where it was said over and over again that the best environment for seniors to live in is in their own home. But is that true? Like, is it better if they're in a assisted living or a nursing home, or is staying at home truly better? I would like to find that out. Also, how do we pay for this? For those that didn't plan and save, or those that are less fortunate, how do we pay for that? Another thing, there are a ton of great providers that are out there in our state. Maybe if we could have some sort of reward for the great providers. And also, this is a new term to me, but solo agers, like you were talking about the women over 65. How many are there of the solo agers? And they often don't have family around to help them care for them, which even creates more issues. Sometimes it's very difficult for them to navigate the situation that they're in. So if there's something that we can set up for these solo agers, that they can identify a person ahead of time, that healthcare can ask on their behalf when it comes to caring for these seniors. Also, what are they doing in other countries? They're way ahead of us on this curve of aging folks. What are they doing in the other countries? I've always questioned if it's our culture or what other countries are doing that is working better than what we're doing here. And then again, the transportation services and more support for family caregivers. I think that would be helpful. I know many of us in this room have cared for our loved ones, and it takes a toll. And so if there's any sort of support for the family caregivers, that would, I know that was a ton, But a lot of ideas I just wanted to throw out that I've been taking notes. And again, thank you so much to all the presenters. Thanks.
Thank you, Senator Housley, and I made notes of at least 8, maybe more, that you have mentioned. So I think those are great ideas and are now on our list. And I want to just remind the group that the idea is that we think broadly. So if you think about what an individual would need to live with dignity throughout the life cycle, from the time they get out of bed in the morning until they get out of bed the next morning. What do we need, what infrastructure do we need in our state to make that the best life possible? And with that, I also have to keep in mind that we have individuals who are incarcerated, and we didn't mention anybody who is in a state facility. So I have no idea what those numbers are. Do you have any idea, Dr. Brower, about either the costs associated with healthcare in our state correctional facility? And if you don't have those, and how many individuals that might be that we would need to factor in our budgets for dementia services or care services?
We do have information on the number of people in correctional facilities. I don't have the number in my head, but I certainly will follow up with it. I don't have information on the cost of care to those folks, but I can try to track down who might have that.
Okay, and I would, our tribal nations, they are also included in the statistics that you provided, the census data that you provided, correct?
That's right.
Thank you so much. I just want to make sure that they're included in the numbers as well. And we can have those presentations also later. Dr. Gogler, I saw that you raised your hand.
Yes, no, thank you. Oh, no, please, why don't you go ahead first?
Representative Zalesnikar.
Thank you, Madam Chair. My question is just, my hope would be that we can move the survey process to a coaching model for scope and severity. And I say that after being in the field for 40 years, watching what's happened. We haven't changed the diseases, but we also have now the worst staffing issue we've ever had in the country. And we have expectations that are up to here of practically one-on-one staffing is an expectation some have when they leave their home to go to a setting. My question is, we're in person-centered care model, and we spend a lot of hours in settings doing intervention after intervention for falls. They could have a break and they fall second, or they could have a fall. And if there's a negative outcome, then there's this notion of liability for people. And so a lot of this comes down to looking at quality and how do you define quality. And I think as a committee here, we can look at some practices, because we are at a different time right now from when I started as an aide in the 80s to now. And so we have to really look at what are we looking at? And I think coaching is a really critical thing for CNAs to have coaching opportunities, because if you're going to feel like you're in a setting of fear, if a care plan's not followed and you're going to have surveyors discipline you or lose your license as a nurse, they're choosing to work in hospitals and other settings because they just feel very degraded. And so we have to bring the respect back for what it is. It's very difficult to be a CNA and a nurse. And if they're not choosing to work in these centers, we want to have the best quality, but we also have to look at the scope of what we're asking people to do in really difficult times right now. And so depending on that scope, I think there's a lot of opportunity. The model, when I look at it, that we have right now, assisted livings were fined $3 million and nursing homes were fined $1 million. And the bigger issue is, what do we gain by this? Because we don't do that in education. We don't do that in many other models of government when we're not having 100% success of what our overall goal is. So how do we create an interest to come into the field and to create a workforce? Because there's many other options, and caregiving is a very difficult job to be an aide when you have the mental health that exists today, and you have the behaviors, and you have 105-year-olds and very frail people. Takes a lot of time, a lot of patience, and we want all those things. So I think we have an opportunity to look at how we're doing it, and then truly look at what is scope and severity, and dig into that so that people choose this. We want people to choose to be caregivers. And that's a big difference. I knew a lot of people that chose to be healthcare givers, healthcare providers, and many are just not choosing it today. And when I ask them why, it's a different workforce environment to be in than if they choose to go work in retail or something else. They're not disciplined in a harsh way every time they make a mistake. And that's not the world that healthcare providers always feel that they're in. So I think we have some opportunities for what it looks like. And I want the highest standards for Minnesota too. I want great things to happen for everybody. But I think we have to look at it because we've not changed Alzheimer's in 40 years I've been doing this. I've seen congestive heart failure and sliding scale insulin diabetics, but we have the biggest group of people aging and the fewest employees that we've ever had. So thank you.
Thank you so much. Dr. Gogler. Oh, Ms. Swilling.
Yeah, I don't know if there's an opportunity to share, publications or anything with both our task force and more broadly, but, one of the most impactful things I've read recently, and it's a very easy to read report, it came out of the AARP, Susan Reinhardt and her team. Susan Reinhardt is one of the great policy aging experts in the U.S., and the whole report basically identified what she considered 6 scalable innovations in long-term services and support that we should be disseminating now. And it really resonated with me because this report and this brief summary more or less coalesced a lot of the things we've already been talking about. Things like one innovation is the green home model for long-term care. And I know we have a few of them in Minnesota. Why don't we have more? And the reason why these innovations, I think, are cross-cutting as solutions is you talk about the challenges of working in the current, quite frankly, often institutional setting of the nursing home or whatnot, and why that can be such a challenging job for an aide. Contrast that to the green home model, which actually offers more of a team-based approach to care, not a regulatory punitive one, where people who are providing care actually see a future for their work and such. And so, that's just but one example. There were several others too. And what I'm trying to get at here is, again, and you heard Lori Rolson talk a little bit about this too, I think, and we can't lose sight of the fact that much of what we want to focus on, in addition to these specific topics, are dissemination and implementation again. If there are good services out there, how do we engage effectively with our communities so they know they're available and can use them effectively? And then 2, implementation, in that we have these innovations available, how do we implement them and scale them effectively so they can help the people who require that help across the state? That, to me, I think that's one of the reasons why our center and myself are so excited to be here.
Thank you very much. Ms. Foley, did you have any comments you would like to make?
No, I agree with a lot of the topics we've discussed today. Some of the transportation's a big one. Getting more vehicles out in the rural areas that have adaptable things for wheelchairs and walkers, because most people that do the rural pickup and stuff, a lot of those don't have those kind of vehicles. So if we can get some of those out in the rural areas.
Thank you very much. As I think about the work ahead of us, remember we are focusing on the large infrastructure. So that is really important. The transportation, we've heard today over and over how important it is for people to be mobile and to be able to get where they need. I'm a firm believer that most individuals know what they need, and we have to remove also the stigma of asking for help and asking for what you need. And so as we normalize aging and we have respect and dignity in aging, I think that will help us move the conversations that we need to have going forward. Dr. Gogler, if you have research that you wish to share that we can post on the task force website for all Minnesotans to have availability to read. That would be a wonderful thing. If it's something that is limited in who you can share it, please make sure that the members of the committee have it, or make it available to the librarians who could then share with us as well. I want to acknowledge the fact that we have quite a few retirees in the audience with us today, so thank you so much for being here. I hope that we've touched on some of the topics that will be of interest to you going forward. I know that pensions are also a very important topic that we'll probably do some diving into. And then, okay, I understand Senator Housley would like to make a few comments before we close, so maybe I'll just stop here and go to Senator Housley.
Thank you, Madam Chair. Sorry to interrupt you. You're on a roll there, but I wanted, if you could add to your list too, if we could take another look at the elderly waiver program and how that could be enhanced or made better, because it is so helpful. But that's one that I forgot to add in my list. And maybe if we had a presentation on it and where there's gaps in that we could maybe fix. That's it. And thank you again, Madam Chair.
Thank you, Senator Housley. And I'm sure that elderly waiver will be a discussion that we have when we have the departments come in and speak to us. So thank you all for being here today. We have much important work to do. All of your voices are important. We will be adding to the task force website a public portal for people to add their suggestions. We do hope to have some listening sessions where we bring the public voice to the table as well. The public voice is such an important part of this work. Please feel free to email, please feel free to write, please feel free to ask to testify if there's a topic that you really need us to hear about. We have many resources available to us, but we want to keep Minnesotans front and center of this conversation. So with that, I believe we're 5 minutes to 12. If there aren't any other further questions or comments, I will adjourn the committee for today. Thank you all for being here.
Recording stopped.